is Ronnie Decker. I am a registered nurse, and this is Nursing Analysis. Today, we will start our NCLEX review on maternity. We will begin with the organs involved and the hormones that are released during pregnancy and their actions. During the antepartum period, the systems in the female body must adapt to accommodate pregnancy and a growing fetus. The endocrine system provides hormones to influence the reproduction cycle. The reproduction cycle has 4 phases: the menstrual, the regenerative, the proliferative, and the secretory phases. The cycle duration will extend from the first day of one menstruation to the first day of the next menstruation, which is typically a cycle of about 28 days in duration. Once an embryo is implanted, the endocrine system changes its response to the reproductive cycle to support the continuation of the pregnancy. Let's now talk about what happens before pregnancy occurs. The pituitary gland secretes FSH and LH, which is follicle-stimulating hormone and luteinizing hormone. These combined hormones will target the ovaries during the ovarian cycle. The ovarian cycle refers to the series of changes in the ovary during which the follicle matures. The ovum is shed and the corpus luteum develops in response to the FSH and LH. Once conception is initiated, which is also known as fertilization or implantation, the pituitary gland will secrete hormones that can stimulate lactation. These hormones are known as prolactin hormones, and they are responsible for the growth of breast tissue and the development of breast milk after the baby is born. The pituitary gland also releases a melanocyte-stimulating hormone, MSH. This hormone combines with estrogen to increase pigmentation. Another hormone released by the pituitary is oxytocin. This hormone stimulates uterine muscle contraction and stimulates milk ejection. It is important to note that oxytocin is used as an exogenous medication to elicit effective contractions during labor. It is also administered following the delivery of the placenta to ensure uterine tone. Intranasal oxytocin spray can be used for milk ejection. This aids in the release of breast milk for breastfeeding mothers who have a delayed letdown reflex. Let's now discuss the adrenal glands and the role they perform during pregnancy. High amounts of estrogen and adrenocorticotropic hormone, which is ACTH, stimulates the release of a hormone called cortisol from the adrenal cortex. Cortisol can affect the metabolism of carbohydrates and proteins. These are necessary for the growth and development of the fetus. Cortisol also causes insulin resistance, which can lead to hyperglycemia, therefore placing the mother at risk for developing gestational diabetes. The adrenal cortex also releases aldosterone, which is a mineral corticoid. Aldosterone is released during the second trimester in response to low sodium levels that are caused by the circulating progesterone. We will now focus on the thyroid gland. Increased levels of the thyroid hormones, which include thyroxine, T4, and triiodothyronine, which is T3, cause an increase in the size of the thyroid gland. This increase continues until the end of the first trimester, and then the elevated levels will remain elevated until the end of pregnancy. We must assure that the thyroid levels are assessed regularly and that the treatment of any hypothyroidism is accurate, as this is critical to maintain pregnancy and also for the fetal brain development. It is important to know that hyperthyroidism, unrelated to pregnancy, can be masked during pregnancy. We cannot rely on the usual symptoms of hyperthyroidism. These include heat intolerance, tachycardia, nausea, and vomiting, as these are normal symptoms during pregnancy. Frequent laboratory testing of the thyroid function is the only way to properly determine any masked hyperthyroidism. Let's now move on to changes in the pancreas. During pregnancy, insulin production is normally increased. This increase is crucial to prevent gestational diabetes from developing. A glucose challenge test is usually conducted during the 28th week of pregnancy. It is very necessary as to identify hyperglycemia. If identified, the initial nursing intervention would be to focus on both diet and mild exercise. Let's now turn our attention to the placenta. This temporary fetal organ facilitates nutrients, gas, and waste exchange between the physically separate maternal and fetal circulations. It acts as an endocrine organ in that it produces hormones that alter the physiological environment. This will support both growth and development. After ovulation, the corpus luteum forms and secretes both progesterone and estrogen. This production will inhibit further secretion from the pituitary of both FSH and LH. The placenta will take over progesterone production and estrogen production by the 7th to 10th week. Progesterone will relax the uterus and suppress any uterine contractions. Progesterone also influences the maternal immune system to accept the foreign fetus. It will prevent rejection. Progesterone slows GI motility, which can cause symptoms during pregnancy. It also causes fatigue in the first trimester. Estrogen stimulates circulation by increasing vascularity. Estrogen also develops the ductal system for milk production. It must be noted, high levels of estrogen can suppress milk production. As mentioned earlier, estrogen and MSH are responsible for hyperpigmentation, as in the condition linea nigra, which is a brownish streak that commonly will appear on the abdomen. The mask of pregnancy, or melasma gravidarum, can also appear. Let's now discuss what happens during implementation. The trophoblast that develops into the placenta secretes HCG, human chorionic gonadotropin. This hormone stimulates the corpus luteum to continue production of both estrogen and progesterone until the placenta is able to take over this duty. Let's now discuss human placental somatomammatropin, also known as human placental lactogen, HPL. This hormone, produced by the placenta, will alter the mother's metabolism. It enhances the carbohydrate, protein, and fat availability for the fetus. HPL is an insulin antagonist. It decreases maternal metabolism of glucose and increases the availability of glucose to the fetus. This hormone also helps with breast development. The corpus luteum produces the hormone relaxin, and the placenta also contributes with production of relaxin. This hormone can relax smooth muscle and will soften the cervix, which can limit uterine contractions. Relaxin also changes the structure of both cartilage and ligaments that support the uterus and cervix. This will allow for growth and accommodation of the uterus and fetus as they grow. We will also briefly mention prostaglandins. These lipids are produced in many organs. They can be used to soften the cervix and to induce labor. It is important to note defective prostaglandin production or a loss of response to prostaglandins can contribute to the development of preeclampsia. We will continue discussing other organs related to this topic, including the reproductive system, in Volume 2 of this series. We will now discuss and review a case study related to this topic. We will now begin our case study. We will begin by discussing Miss Johnson. She's a 32-year-old prima gravida who travels the world as a language interpreter. She is 5 foot 6 inches tall. She weighs 132 pounds. She has pink skin tone and appears to be well groomed. This pregnancy was not planned, and Miss Johnson has concerns that conceiving might be difficult. Upon arrival for her first prenatal visit, the nurse collects her history. Miss Johnson is not married and reports no family history of genetic disorders. Miss Johnson reported using hormonal birth control. However, she has not been taking her birth control pills for the last 12 months. She reports her last menstrual period started 9 weeks ago. Miss Johnson provided up-to-date vaccinations and also denies any history of sexually transmitted diseases. She also denies smoking or alcohol use. Miss Johnson reports a varied diet history with adequate proportions in all food groups. She complains of intermittent nausea and extreme fatigue, and she questions if this is a normal occurrence during pregnancy. She states that recently she has only been able to tolerate small meals, and sometimes eating will actually relieve the nausea. She states that she usually exercises by walking every day around the block in her neighborhood. However, due to the fatigue, she has not exercised in weeks. Miss Johnson also reports not being able to travel related to the nausea and fear of becoming sick while traveling. She also reports a constant feeling of thirst and frequent trips to the bathroom, and she has noticed a thick mucus vaginal discharge. As we collect Miss Johnson's vital signs, we can see here that her temperature is 98.6, her pulse is 82, her respirations are 20, and her blood pressure is 108/70. Now let's discuss some other things that we should assess as the nurse. We will begin with level of consciousness. We assess Miss Johnson's LOC, and we are able to determine that she is alert and able to give a history. The second thing the nurse needs to assess would be Ms. Johnson's body mass index. As we calculate the body mass index, we find that Ms. Johnson's is 22. If we remember our normal body mass index, normal BMI would be between 20 to 25. We now must assess the skin. As we look thoroughly at Ms. Johnson's skin appearance, we notice that it is slightly flushed. Her hair is clean and styled. There are no presence of pallor or cyanosis, and her nails are well manicured. We must also obtain a urine sample. We will obtain this sample so that we can possibly detect any abnormalities in the urine, including proteins, glucose, ketones, or any signs or symptoms of infection. And our last assessment would be of the labs. We need to obtain blood work from Mrs. Johnson so that we can ensure that all of her electrolytes are in balance and both her H and H are in order as well, her hemoglobin and hematocrit. We will also keep an eye on her platelet levels. So now let's go over some questions in relation to Ms. Johnson's presentation. How long will Ms. Johnson be able to travel for her job? We need to remember that inactivity in this case would not be a good thing for Ms. Johnson. As we remember, inactivity can lead to the development of a deep vein thrombosis. As long as she does not remain inactive, this will decrease her risk for the development of a DVT. She should wear compression stockings. She can travel. However, it is recommended that in the third trimester, she should remain close to her primary provider. Ms. Johnson asked the nurse when would she get her energy back. We need to educate Ms. Johnson and inform her that toward the end of the first trimester, until then, she should plan for frequent rest periods. She needs to keep hydrated and avoid caffeine. As the nurse, we must constantly review any possible risk Ms. Johnson may face during her pregnancy. Based on her history, she is considered a low-risk pregnancy. She should still be cautioned of possible spontaneous miscarriage. Further risks involve travel with extended periods of inactivity, which can contribute to the development of a DVT. She should be advised to increase her fluid intake. She should be provided with an emergency contact number for her obstetrician. Well, this concludes our first volume on our maternity series. It is now time for our Rhyme Time Review. We must discuss a day of much celebration, the beginning of pregnancy and the end of menstruation. FSH and LH secretion comes to an end, as the hormones of pregnancy, progesterone and estrogen, begin. On to the adrenal gland and its role. Secretion of cortisol is its goal. Cortisol has many effects, some that interfere with metabolism and some we respect. Aldosterone sets the tone for conservation of low sodium caused by progesterone. T3 and T4 start to rise, causing the thyroid gland to increase in size. On the thyroid hormone, we need to keep a close tab and continue to check all of its labs. Moving along, what organ is next? We will now discuss the pancreas. As the insulin increases, hyperglycemia ceases. we must just briefly speak about the 28th week. The sugar must be checked and compared to the rest as we perform a glucose challenge test. And if the sugar starts to rise, we must teach our patients diet and exercise. Let's now talk about the baby's protection. The placenta needs thorough inspection. Remember the brain and the functions of the endocrine. The placenta does the same with just a different name, allowing the fetus to develop and grow by causing estrogen and progesterone to flow. Progesterone slows GI motility, whereas estrogen has a different ability. Stimulation of milk production, increasing vascularity to prevent reduction. Estrogen has another relation, as it pairs with MSH and causes hyperpigmentation. One other noted task, on the face it forms the pregnancy mask. Thank you for taking the time with Nursing Analysis. Thank you for all the support we have received. Please continue to like, subscribe, and share so that we can continue to provide you with great educational content and future videos.
As a nurse, we have the opportunity to heal the mind, soul, heart, and body of our patients, their families, and ourselves. At Medical Prep Institute, we want to give you the opportunity to become that nurse. We can provide an exceptional education from professional and knowledgeable instructors with modern and upgraded facilities. Call or email us today so we can help you become that nurse.